myself. My name is Walaa, consultant pediatric immunologist allergist. I'm an assistant professor in the faculty of medicine at معاكم doing your module. Hope you've enjoyed so far what's finished so far. إنه هلا أنتوا خلصتوا الدكتوراه صح؟ أبدأكم 2 weeks. Oh, what are you doing yet? How is everything so far? Good. Just a few points before we start. First of all, I would like to stress on how important it is to mutually respect each other, okay? As I sacrifice my time and efforts to come and give you lectures, hopefully you'll get the benefits out of them. Please do respect my presence here, no side talks. If you'd like to throw any comment or question, please raise your hands. It's very important for you to make sure that you don't exceed the allowed absence during the day. Previously, and I'm sure, I'm quite sure this is the same for this one here. We used to like, for your evaluation, final evaluation mark, for each absence, we know like excuse you'll have one mark, and you'll have 1 mark taken off your evaluation, total evaluation. So it has a good weight from your total evaluation mark, okay? الأعذار الطبية أكيد خبرتكم دكتورة أسيل لازم تكون من مركز صحي أو مستشفى لازم تكون في presentation diagnosis procedures انعملت during the medical evaluation when you were evaluated لازم ختم الدكتور اللي evaluated you signature and the stamp للإنستيتوت كنت فيها يعني ختم مركز صحي ختم المستشفى etc. Otherwise the medical report would not be right. Okay. I think لازم نسكر الباب. We'll be having 2 lectures for today, lower respiratory tract infection or pneumonia in specific and meningitis. Have you seen any cases of pneumonia? So you do clinical rotations now, صح؟ مستشفى رحمة وغيره. So have you seen enough cases of meningitis and pneumonia? Okay. So I think there's a good bulk of you who had 1 or 2 of the cases. Okay. Right. Upper versus lower respiratory tract, because it's very important to clinically be able to tell whether it's an upper respiratory tract or lower respiratory tract infection. Because the etiology is different in most of the cases, and the management is quite different between both, depending also on the age group that you are dealing with. When we say upper respiratory tract, it's anything above the thoracic end, or to be more specific anatomically, anything above the vocal cords. Anything below that, this is the lower respiratory tract, okay? So the upper respiratory tract is nasal cavity, pharynx, oropharynx, larynx, sinuses as well, okay? And lower respiratory tract, it's the major airways, the large airways, smaller airways, and the lung, right? Okay? And don't forget the pleural itself, as the presentation might be confined to the pleural as well. Okay, so because we're going to be focusing on the lower respiratory tract, basically because the lower respiratory tract is a major site at which gas exchange happens. Okay, so again, clinically, you should be able to tell whether the patient is having a lower respiratory tract based on the signs and symptoms you observe, like, for example, hypoxia, intercostal retraction, etc. Okay, so any pathology, if it's severe enough, it will affect the major function of the lower respiratory tract, which is gas exchange. Okay. Now, what infections do we need by lower respiratory tract infections? Any thoughts? So it's either pneumonia, bronchitis, or bronchiolitis. So, for example, between bronchitis and bronchiolitis, it's quite similar, the nomenclature. but the anatomical structure and the presentation might be again different and differs from one age group to another. Okay. Alright, so pneumonia. When we say pneumonia, we mean inflammation of the lung parenchyma itself. Alright. So there's two different terms that you need to differentiate between. We have pneumonia and we have pneumonia. When we say pneumonia, we mean infection that has led to inflammatory process in the lung parenchyma, okay? And either it's a pyogenic infection or non-pyogenic infection according to the causative pathogen, okay? The term pneumonitis is rather a general term to describe that there is a diffuse inflammatory process in the lung parenchyma, possibly without consolidation, possibly without pyogenic infection. Alright, and this can happen due to so many causes. For example, if you inhale corrosives like kerosene or whatever other corrosives, you might get the as a sequelae pneumonitis. This pneumonitis in patients admitted with inhalational injury can be only confined to pneumonitis as inflammation, but some of them might develop secondary pneumonia as well. Okay. Because as we say, the structure where gas exchange happen, kids with pneumonia might expect them to present with signs of respiratory distress like tachypnea. So in literature, they say it's highly unlikely to evaluate a kid with pneumonia without tachypnea. Alright, it's very highly unlikely. Alright, specifically if we're talking about lobar pneumonia, where a whole lobe or more than one lobe of the lung is affected. Other symptoms might include fever, as any infection, as an immune and inflammatory response due to cytokine and inflammatory mediators release. Other signs of respiratory distress like grunting, tachypnea, dyspnea, cyanosis, retractions. Yes. So what types of retractions do we mean by when we say retraction? Okay, so we have suprasternal retractions, intercostal and subcostal retractions. If I want to pick between the three of those to say that this retraction is most likely due to pneumonia or lower respiratory tract infection, I would choose intercostal retractions. We can quite see in so many cases suprasternal due to upper respiratory tract infection. Nasal obstruction can cause subcostal retractions as well. Okay. I was mentioning that if I want to choose between the three to say that this is caused by pneumonia or rather interstitial lung involvement, I would choose intercostal retractions. For subcostal, it's not only can be caused by pneumonia or lower respiratory, upper respiratory involvement can cause subcostal retractions. So if you evaluate a 1-year-old kid with significant nasal obstruction, you might observe subcostal retractions as well. Okay? So the etiology of pneumonia is variable. In all age groups, the most common cause is viral in all age groups collectively. Others like bacterial, fungal, for example, specifically in immunocompromised kids, and parasitic infections as well, or atypical microorganisms. All right. So we have divided pneumonia into actual pneumonia with consolidation or pyogenic pathology or an infectious pathology and non-infectious or inflammatory like pneumonitis. Other way to divide pneumonia or to think about classification of pneumonia is lobar and non-lobar pneumonia. When we say lobar pneumonia, then the infection has taken a lobe of the lung, so it has happened in one or more of the lung lobes. So if we're talking about the right lung, for example, it might be middle and lower lobe, or middle lobe only, upper lobe only, etc. Okay, so lobar is confined to one lobe. When we mention bronchopneumonia, which is most likely caused by viral etiologies, plus, minus, sometimes atypical pneumonia, the X-ray findings won't be confined to one lobe. It would be rather patchy, discrete, infiltrate, bilateral. It tends to be homogeneous most of the times. So what you see in the right lung, you are able as well to see in the left lung as well. So it's more of homogenic, patchy, and filtering bilaterally. And interstitial pneumonitis mentioned, there are so many causes for interstitial pneumonitis as inflammatory process. As I said, inhalational injury, for example, related to work or non-work related. Some immune and rheumatological manifestations or diseases can cause pneumonitis, like a Sjogren disease, for example, SLE pneumonitis as well. Radiation therapy, sometimes chemotherapy can cause, immunosuppressant can cause pneumonitis. All of these can be a primary cause of inflammation in the lung parenchyma or pneumonitis. Okay, so again, another classification of pneumonia is community-acquired pneumonia and hospital-acquired pneumonia. Okay, so can you tell the difference between them? So why do you think we have this classification? So why did they bother to classify pneumonia as hospital or community? Because at the end, it's pneumonia and we need to treat. So why did they bother? So the reason why, because they want to identify groups at which their pneumonia is most likely related to resistant pathogens. Okay, and this is what we see if pneumonia was hospital acquired. Bacteria in hospitals, you know that by now, tend to be drug resistant because of the significant exposure to antibiotics in the same environment. Okay, and it can be different from one institute to another. So, an institute where there's no antibiotic stewardship, or there's no control of giving antibiotics, you might find higher resistance rate than another institute in the same country or the same region if the antibiotic use is more well controlled. Okay? So again, this classification tells me which patient is at risk to develop pneumonia due to a resistant microorganism, and subsequently I might expect the course to be more severe than those with community-acquired pneumonia. However, bear in mind that with community-acquired pneumonia, pathogens which are responsible for pneumonia in community are now gaining resistance, unfortunately, due to the excessive use of antibiotics. Okay? So when we say hospital-acquired pneumonia, it has to be observed in the first 48 or 72 hours of admission. Okay? So if someone asks, so if the patient was admitted, for example, today, and 4 days, 5 days later, when they were discharged home, they developed signs and symptoms of pneumonia, what can we call this? What do you think? No, he wasn't admitted initially with pneumonia. So, for example, someone was admitted with appendicitis and has undergone appendectomy, and then discharged home, and on day 5 of discharge, he developed signs and symptoms of pneumonia. Do we still call it hospital-acquired pneumonia?
Aspiration.
He didn't aspirate. What should we call it? In a hospital-acquired, it's diagnosed within the first 48 to 72 hours of admission, right? So there's another entity that they came up with for those like in the gray area who started to develop signs and symptoms of pneumonia beyond this period. We call it healthcare associated pneumonia. Okay. For example, someone who attends nursing centers, like elderly people, someone who goes back and forth to hospital for example, dialysis, into a dialysis unit. They don't get admitted overnight. So they go for dialysis and then they get discharged, right? Someone with contact with healthcare professionals, again, okay? Hospitalization in the past 90 days, this is also considered healthcare associated pneumonia. If it was a central line insertion as well and discharge home, if the patient has had IV antibiotics in the past 30 days. So this is another term to describe again those at risk to develop pneumonia due to resistant microorganisms, but we can't call them hospital-acquired or nosocomial. Okay? And you need to know that in hospital-acquired pneumonia, the scale would bend towards bacterial etiology rather than viral etiology. Okay. So again, another classification, typical and atypical pneumonia. Again, why this nomenclature? Why did we come up with atypical pneumonia? What do we need to describe?
Type of bacteria. Type of bacteria.
So excellent, this is one of the causes. So when we say atypical pneumonia, then causative pathogen is not a typical one for community acquired, or it's not a common one. So this leads us to say, what is the most common cause of community acquired pneumonia? Streptococcus pneumonia, okay? So when we say atypical pneumonia, that's because first of all, the pathogen is not typical in comparison to community acquired causative agents. This is number one. Number two, the course as well is atypical or different. So usually, clinically, when a kid is presenting with bacterial pneumonia, for example, strep pneumonia, okay, the kid most likely will have high-grade fever, will look ill, toxic, tachypneic distress, maybe hypoxic, right? Signs of respiratory distress are very, clear on physical examination, but this is the typical scenario for bacterial pneumonia. However, when we talk about atypical pneumonia, the clinical course and presentation is quite different. So usually we call them walk-in pneumonia. They walk into you, they're looking good, they're not very ill, they're not in distress, okay? They might mention a history of low-grade fever, malaise, feeling slightly unwell, maybe dry or wet cough, and then you do X-ray. You'd expect the X-ray to be okay, but then the X-ray will show significant changes, interstitial changes on what we call bronchopneumonia, bilateral. So this is what we call walk-in pneumonia, because kids or patients are usually doing really well clinically when you see them, but the X-ray is bad. So there's a discrepancy between the X-ray finding and the clinical presentation. This is another reason to why we came up with this classification of atypical pneumonia, because the clinical course is atypical. Another difference is that with atypical pneumonia, it's a bit difficult to diagnose because pathogens are atypical, and usually you need specific PCRs and specific serological evaluation to diagnose them. Okay, this is not the case with the typical types of pneumonia. So the most common cause of typical pneumonia is, when we talk about community acquired, is Streptococcus pneumonia. Okay. For atypical pneumonia, it can be due to viruses like influenza virus, adenovirus, or mycoplasma pneumonia, chlamydia, etc. The age at which they present with atypical pneumonia is also quite different, okay? So it's very specific to those above 5 and some 15 years of age, okay? So 5 to 15, you need to suspect atypical pneumonia, and you need to cover pathogens that commonly cause atypical pneumonia like chlamydia and mycoplasma, because their coverage is not typically what you cover with if you treat streptococcus pneumonia, okay? So this, just again to mention common signs and symptoms of pneumonia clinically, and physical exam, as we mentioned, signs of respiratory distress, tachypnea, intercostal retraction, grunting, for example, maybe added sounds, wheezes, and atypical pneumonia is a common as well. Crackles or crepitations, decreased air entry on the side involved if we're talking about lower pneumonia, etc. You need to know after this table that for when you evaluate for tachypnea, the respiratory rate is age dependent. Okay, so what you'd expect, what you would accept as normal respiratory rate, 1 year old, for example, 50 is considered. 1 year you can accept up to 40 to 50 breaths per minute. However, if you're evaluating someone who's 14-year-old above 20, this is tachypnea. So just be vigilant to the age-related respiratory rate. So this is some references to go to that has the patterns of different patterns of abnormal breathing sounds, like vesicular breathing, bronchial breathing, and trumpets. Okay, so how to diagnose pneumonia? So, by clinical diagnosis. So you have high index of suspicion. If you are evaluating a kid who's febrile, ill-looking, tachypnic, and showing signs of respiratory distress, you say, I need to rule out pneumonia, right? So clinical diagnosis. And we have radiological diagnosis, which is basically simply doing an X-ray. And usually we tend to order two views, an X-ray with two views, AP, anterior posterior view, and the lateral view. Because sometimes you won't be able to, if the pneumonia or the involved in the posterior aspect of the lung, sometimes it's very difficult to appreciate. Again, right mid low pneumonia, sometimes it might be deceiving to recognize on simple AP views. Okay, other investigation that you might order. CBC, what would you look for in the CBC? Leukocytosis, okay. And if it's bacterial pneumonia, so benzemia or shifting to the left with more immature neutrophils being produced. What else? Like we talk about differential of white cell count. So there's leukocytosis, and if it's bacterial, you will have neutrophil predominance, more production of neutrophils, or we call shift to the left band cells production. Okay. What else? Looking at a CBC for a kid with pneumonia. Okay, that's the differential of the CBC. Okay. What else? How about platelet count? Excellent. Should be still with sepsis. So, if it's severe refractory sepsis, or what we call TRC, there will be thrombocytopenia as a manifestation. On contrary, they can have thrombocytosis or increased platelet count if it's not septicemia, because platelets simply is an acute phase reactant. Okay, so they react with any inflammation, any infectious process. So you might have thrombocytosis. Okay, what's the significance of blood cultures in kids with pneumonia? Is it like a common practice, and how informative is it? Blood cultures. So theoretically speaking, we send culture when we suspect bacterial etiologies. Are they that informative in pneumonia in specific? So, blood cultures, if you're talking about someone with hospital-acquired pneumonia, can be, if it's bacterial, can be positive in up to 25, best case scenario, 25%. So if there is 100 patients admitted with hospital-acquired pneumonia, okay, and it's bacterial, only 25 of them will have positive blood cultures, okay? And the percentage is much less significant if we're talking about community-acquired pneumonia. So in best case scenario, it might be up to 15% only. So it's not if you're admitting someone with pneumonia, you need to start antibiotics, right? You can't start antibiotics without sending a blood culture. So this is like a specific guideline or practice. So if you want to start any antibiotic, you have to send blood culture. But we're talking about the yield of cultures in patients with pneumonia. How much would I yield after sending the blood culture? Knowing the etiology, okay? So community-acquired pneumonia, in best case scenarios, up to 15% of them will have positive culture. cultures, percentage can go up to 25% if it's hospital acquired or if you're dealing with someone who's really ill and immune compromised. Okay. And the likelihood for the blood culture to be positive depends as well on other factors. Like if the patient has already received antibiotics, like coaxiclav or like antibiotic, the likelihood that you will have positive blood culture is less. Okay. If the patient is initially septic and then secondary to that he develops pneumonia, the likely chance of this patient to have a positive blood culture is higher because it's disseminated from blood, so the origin is in blood, so you'd expect the blood culture to be positive as well. Okay. Again, if the patient is very sick, in septic shock, etc., again, the percentage of having a positive blood culture is higher. And we know it sometimes sends sputum cultures, but this it's very difficult in certain age groups to ask them to expectorate and produce a decent amount of sputum to be cultured. Okay, the process of expectorating is not very pleasant, and not all age groups can do that. And you actually need to have secretions from down below to yield something in the culture. However, most of the sputum cultures that doctors tend to send are upper, so the secretions are from upper respiratory tract, so they wouldn't be as informative as you'd expect. Okay. So indication for admission كل جروب بعطيهم بيكون دائما في debate عن حاضرة النمونيا إنهم مش عارفين شو indication for admission, because some slides would say less than 2 months, some slides say less than 6 months. Okay, so what's right and what's wrong? Okay, but indications for admission, like generally speaking, less than 6 months. So let's start with this number, 6 months. This is not absolute. Okay, so if I have to choose a specific age group to say that this is an absolute indication, absolutely the kid needs to be admitted to hospital to treat pneumonia, it's from 0 to 3. So any kid below 3 months with pneumonia has to be treated as inpatient, period, okay? There's no debate about this. Now, the critical age group, or the age group where it's more depending on your clinical evaluation and the clinical situation of the kid, is between 3 and 6 months of age. Okay, so this is a bit, it's not wrong to say that I have evaluated a 5-month-old kid who presented with cough, low-grade fever. I did an X-ray. The X-ray showed pneumonia, but the kid was clinically very well. He wasn't sick. There was no high-grade fever. The kid could maintain oral intake, so he can have fluids and food at home, and they can tolerate oral antibiotics. So I think I can discharge this baby to be treated for pneumonia at home, giving the family very strict instructions about what red flags to observe. So I would tell the family, if he develops tachypnea or increase in the pattern of breathing or the breathing effort, if the patient becomes lethargic, high-grade fever, can't maintain oral intake, you need to bring him back to be admitted. But how applicable is this? Again, also depends on how well educated the family is. So if I'm talking to a very well educated, from a good socioeconomic state, someone can, who knows or educated about pneumonia and signs of respiratory distress, who can actually interact with you, and you would guarantee that they are observing what you want them to observe, that's fine. However, if the same kid who's well looking, who's 5 months old, and he's not showing signs of respiratory distress, if I look at their family or parents and say, I don't think they're able to recognize red flags, then the decision will shift towards admission. Okay? So عشان ما أخربطكم, generally speaking, kids below 6 months of age, you tend to admit them to be treated as inpatient for pneumonia, because this is the age group where they can deteriorate quickly and they can get really ill very quickly. okay? And the presentation sometimes can be deceptive, so they can be well today but unwell tomorrow. It's absolutely an absolute indication to admit them below the age of 3 months. Between 3 and 6, sometimes it's up to your clinical judgment. Okay? If you are in any doubt, admit. Okay? So زي بالعربي أو بالعامية يعني زي كأنك أنت بالإيج between 3 months و 6 months بتدور على حجة إنك تدخلهم. أي شيء أي سلايد observation ما ريحتك بتدخل. Okay? But again, إذا أنت واثق من إنه الكid can be treated at home and the family are educated and can observe red flags, you also can send them to be treated at home. واضح الأمور؟ Okay. Other implications for admission: any toxic looking, any ill looking kid with pneumonia needs to be admitted to be treated in hospital. Kids with persistent vomiting who cannot maintain oral intake and can't have oral antibiotics as well need to be admitted to be treated as inpatients. Okay? If the kid has any significant comorbidities that might put them at high risk to develop severe pneumonia, like, for example, diabetes mellitus, immune, cystic fibrosis, severe asthma with previous, for example, severe attacks required ICU admissions, for example, someone with congenital heart disease, whether it is incompletely repaired or unrepaired, we need to admit and treat in hospital. So these are the main indications. DSAT, hypoxia, okay, this is an absolute indication. So SAT, any SAT that's equal or less than 92% means hypoxia and need to admit the patient to be treated in hospital. As I said before, tachypnea is age-related. Okay, so this is what I was talking about. So when I say the age between 0 to 3 months, they need to be admitted. Absolutely, this is an absolute indication. Why? What's the point of view? So when I say the age between 0 and 3 months, this is an absolute indication to admit for pneumonia regardless whether they're looking well, they're fine, there's no DSAT, they can maintain oral intake, you need to admit them. Why? Okay, so you mentioned the word septic, because in this age group you have to treat or to rule out sepsis. So we don't admit them to treat pneumonia, right? We admit them with a presumptive thought of sepsis. So pneumonia can be a manifestation of rather septic patient. So, for example, babies born with GPS pneumonia. Do we treat them as, for example, 1 month old, but living with GPS pneumonia? Do we treat them only for pneumonia? No. So this is a critical age, so we need to do full sepsis workup, to send cultures like urine, CSF, blood culture, and admit to treat as sepsis. Okay, and they can deteriorate really quick. They can deteriorate and get sick really quick. Okay, so this age group is not only pneumonia that you are targeting here. Okay, so the most common pathogens in this age group to cause pneumonia or sepsis or sepsis. For GBS, as you already know, group B strep, GBS, E. coli, and Listeria monocytogenes. Well, Listeria, we always say the only place where you see Listeria is in box. So I've never seen any kid with positive culture for Listeria monocytogenes, but you have to cover it with proper antibiotics because you never know, maybe this kid is 1 in a million who develops Listeria monocytogen sepsis, okay? So the choice for antibiotic will target the most common pathogens causing sepsis and pneumonia in this age group, which are again GBS, E. coli, and Listeria monocytogenes. So you need to have both, as you notice. E. coli is gram-negative, GBS is gram-positive, right? So you need to cover both gram-negative and gram-positive. So the choice of antibiotics, it needs to be broad spectrum antibiotic covering both. So it's either ampicillin cefotaxime or ampicillin gentamicin. Okay? And ampicillin is specific to cover Listeria monocytogenes. And the duration of treatment is 7 to 10 days. Okay. So the other debatable age group that we just mentioned, 3 to 6 months of age, you treat empirically covering the most common pathogens to cause pneumonia in this age group, which are Streptococcus pneumoniae and Haemophilus influenza. The choice for antibiotic depends whether you're treating inpatient or outpatient. As I said, you can treat a 5-month-old kid with pneumonia as outpatient, right? So just mention when and how. And the choice for antibiotic, because the treatment is outpatient, needs to be an oral antibiotic, so it's coamoxiclav, okay? Amoxicillin is the first choice, but in our area, because in Jordan, plan jobs أو زي العين كده بنصرف at the status febrile illness دائما الأهالي ما بيكتفوا إذا رفع صدري أخذ أوكلان أو رفع دكتور شاطر وبيعطي أوكلان كتير okay but this caused emergence of resistant strains. So now in our country, unfortunately, you can rarely find pneumonia that can improve with amoxicillin. So you start with packet like that, coamoxiclav, okay? Other options for inpatient treatment is ceftriaxone and ceftriaxone. They both have gram-negative and gram-positive coverage as well, and the duration is 7 to 10 days. Be aware of the other age group that we have mentioned, 5 to 15 years old. If you suspect atypical pneumonia, you have to add antibiotic that covers atypical pneumonia like azithromycin or clindamycin. Okay. Complications of pneumonia. Obviously, we mentioned sepsis. So it's either started as sepsis and disseminated to cause pneumonia or vice versa. Bacteria can start inoculating the lung itself and then can disseminate backwards to the blood, causing sepsis. And with sepsis, it might progress to GIC or septic shock. Okay. Other complication is parapneumonic effusion. So there's pneumonia in the right lung. The pleura gets involved, and now there's collection or effusion inside the pleural cavity or the pleural space. We call it parapneumonic effusion. This effusion can be inflammatory, non-infected, or pyogenic or infected. Okay? If it's pyogenic or infected pleural fluid or parapneumonic effusion, then the baby will not improve with sometimes IV antibiotics, even if you start the highest broad spectrum, you added vancomycin, etc., because it needs to be drained, okay, so that the antibiotic can work and penetrate, okay? So looking at the X-ray on the right side, it's very obvious. So can you see the left costophilic angle? كيف تعرف إنه في effusion؟ من الأنجل صح؟ تكون obliterated. So this is a very healthy looking right angle صح؟ But you can't see the left angle صح? So this is effusion. We call it parapneumonic effusion because we know that the patient presented with lobar pneumonia, okay? And this also is shown very well on the CT. However, I can't tell whether this is infected pneumonic effusion. It's clinically, if the patient is not responding, persistent high-grade fever, despite broad-spectrum antibiotic, the patient is getting sicker with time, more respiratory distress, and most likely this is infected pneumonic effusion that needs surgical intervention, drainage, okay? It needs to be drained, as you can see here, okay? So this is a chest tube or a drain draining infected, possibly, because the illustration is showing yellow. They wanted you to think about pus or infected pneumonic effusion, okay? So chest tube was inserted in this patient, and then the patient should have on top broad spectrum antibiotic for a more prolonged period. So typically 7 days, this is for smooth like course pneumonia. It's complicated with empyema, so infected pneumonic effusion, we call it empyema. If it's infected or if it's empyema, the duration can extend to 2 to 3 weeks according to clinical presentation. Okay. Now, if the patient is showing infected pneumonic effusion, which indicates severe pneumonia, you have to think of resistant bacteria or resistant pathogens that caused this pneumonia to become complicated, right? So a simple, susceptible strep pneumo wouldn't cause empyema. It's resistant strep pneumo, okay? So the choice of antibiotic might change. So you admit the patient, you want, 4-year-old, diagnosed with pneumonia. The most common cause of acquired pneumonia is strep pneumo, okay, then ceftriaxone should be enough. You start ceftriaxone, the patient deteriorated, X-ray shows empyema, the patient needs intervention, surgical intervention, and needs medical intervention. So you need to escalate with your antibiotics to cover a presumptive resistant microorganism, okay? So for example, you add vancomycin to cover resistant strep. So the choice of antibiotic would also change. Some books would say you can add clindamycin. Do you know what's the problem with clindamycin? So clindamycin covers strep, resistant strep, fine. It covers staph, MRSA, resistant staph. So why sometimes clinda is not a good option? شو حكينا الكومن كوز اوف كوميونتي اكوارد نمونيا بهذا السلايد؟ شو كمان؟ اقرأوا. Haemophilus influenza. So clindamycin has a poor activity against Haemophilus influenza. So sometimes we're cautious and we start vancomycin from the beginning, okay? Or you add ceftriaxone with vancomycin to cover Haemophilus because it responds well to ceftriaxone. Banco, it's gram-positive, resistant Staphylococcus aureus, like what we call MRSA, resistant strep pneumo. So it means. Should I add? Okay, so clindamycin, what's the coverage of clindamycin? Gram-negative. صح والهيموفيلس. But it has poor activity against Haemophilus influenza. So that's why your choice of antibiotic should include ceftriaxone, بالإضافة إلى vancomycin if you're dealing with someone with complicated pneumonia. Okay? Right. So this is one more complication of pneumonia, which is lung abscess formation, and this is what we commonly see in staph pneumonia. Very well loculated area of cystic formation and abscess. Okay. This is another. So can you see that area of abscess formation and the left lower? Sorry? كم لوب في الليفت لونج؟ ما في ميدل صح؟ When do we suspect complicated pneumonia? So as I mentioned, deterioration in the clinical presentation or clinical picture, persistent fever, deterioration in the respiratory status, respiratory distress, poor response to antibiotic, and again, what's the X-ray and CT are telling you? Okay. Tuberculosis is a serious yet very uncommon cause of pneumonia. Okay. So it's caused by mycobacterium tuberculosis, which is an acid-fast microorganism, meaning that you can't do regular gram stain on it. So So the gram stain wouldn't yield any result. You need to do Nielsen stain, which is specific for acid fast organisms. Okay. When do we suspect tuberculosis? Obviously, if you're living in an endemic area, زي المنطقة مثلا refugee camps, for example, people who are living with elderly who have persistent respiratory symptoms, someone who's coughing continuously, chronically for the last at least 3 weeks, night sweats, fever, chills, weightless, sweats. Okay. You know that tuberculosis has many types. We have the cavitary TB, so it will cause cavitation in the lung, again, very well demarcated area, or miliary. Miliary, it's widespread hematogenous dissemination of TB. Okay, so it's hematogenous dissemination. On the right, it's the cavitary, that you see the cavity on top. On the left, it's miliary or disseminated. I think it's اللنغ زي المنخل بتحسوها. Okay? Okay. هلا أول شيء بتعمله to isolate the patient in a negative pressure room. خاصة symptomatic respiratory symptoms, not the patient is contagious. Okay? To start, you need to do tests. Usually they say do the PPD test, but if the patient is vaccinated, the PPD test can be positive due to the previous vaccination. So you send quantiferon test, called quantiferon is specific for tuberculosis, and the Nielsen stain. For example, if you do bronchoscopy, you got fluid from there, from below, you can do Nielsen stain, for example. Okay? There's specific diagnostic methods for tuberculosis. Again, you wouldn't have positive blood culture, the regular blood culture. Okay. So latent TB, patient with latent TB there is and tend to have normal radical evaluation. As I said, when suspected, you have to apply airborne precautions, negative pressure room, N95 masks, so the regular masks are not enough. You always need to look for the source, whether it's somewhere in the household, an elderly person, etc. They say that children less than 10 years of age are rarely contagious. Why? So they need to cough and produce droplets, as complications to be spread. Children less than 10 years, it's very difficult for them to expectorate and produce strong cough enough for them to be contagious. Bronchiolitis. هحكي بسرعة لأنهم سهلين هدول. So bronchiolitis حكينا involvement of the smaller airways. Hallmark of bronchiolitis: inflammation, excessive mucus formation, وبالتالي airway narrowing and respiratory distress. Okay, its most bronchiolitis is a viral caused by a viral etiology. So usually there is significant trials in the case of bronchiolitis between December and March, which is the beginning of winter. It's a disease of infancy, so kids with 2 years, less than 2 years of age. So you don't diagnose bronchiolitis in a 5-year-old kid, okay? And the peak age is between 2 and 6 months. Pathogen most common RSV, and then other viruses, human metapneumovirus, parainfluenza, influenza, adeno, rhino, coronavirus, and mycoplasma pneumonia that either cause non-viral bronchiolitis. Okay. Bronchiolitis is not an easy disease. It can be life-threatening, can have a high mortality rate, specifically in those who are susceptible to have the more severe picture like those with cardiac problems, immune compromised, as I said previously, hemodynamically unstable congenital heart disease, neuromuscular disease a problem because they have hypotonia, they're unable to clear out their airways, and thus secretions will tend to accumulate more and more, causing significant distress and obstruction. It's with immune deficiency as well that present with severe picture. So this is the prodrome, just to tell you about the prodrome of the illness and how symptoms get worse and peak at day 5, and then they usually tend to improve if they are previously healthy. A physical exam, what would you observe? So it's a lower respiratory tract infection, so they might have respiratory distress signs like tachypnea, sometimes apnea in very young infants, fever, malaise, decreased oral intake, cough, and wheezy chest. Okay? The diagnosis is clinical, however, sometimes we need to send PCRs. ليش؟ لأنه for example, if it's you want to know whether this is RSV related bronchitis, for example, because RSV is very, very highly contagious. So if the patient is RSV positive, you need to isolate. You have to apply contact and droplet isolation precautions. Okay? And sometimes we need to do the PCRs لأنه بالمستشفى نعمل شيء اسمه cohorting. يعني إذا أنا ما عندي enough isolation rooms بعمل cohorting بجمع الأطفال اللي عندهم RSV in one room. What's the worst that can happen? كلهم عندهم RSV مش راح يعدوا بعض. Okay? So sometimes we need to send those PCRs to do cohorting or for the sake of isolation. If the patient is admitted in a ward, your kids who receive, for example, chemotherapy, immune compromise, you need to know عشان contact precautions as well. Okay? The X-rays usually doesn't yield anything. The only thing that you might observe in most of the cases is hyperinflation of the chest. Sometimes some bronchopneumonia infiltrate, very minimal. Treatment of bronchitis is always supportive. Okay? If they are febrile, give them antipyretic. If they are wheezy, you might trial of bronchodilator, trial. So it shouldn't be on the regular treatment regime for the patient. So you give one dose of, for example, salbutamol. You observe. So you say before salbutamol, the patient was tachypnic, the respiratory rate was 70 breath per minute, he was retracting, and his SAT was below 92. I gave one dose of salbutamol and then reassessed after 10 to 15 minutes. The kid is more comfortable, the respiratory rate dropped to 40, for example, he's not anymore hypoxic. I think objectively the patient has responded to salbutamol, then this can be put as regular treatment regime. What you will see in some hospitals that kids with bronchitis are on bronchodilators, are on epinephrine and antibiotics, which is wrong. Wrong. And it's a very rare cause of bronchitis, mycoplasma pneumonia, so you wouldn't think of it as a top of your differential.
Secondary bacterial infection?
Yes, you suspect secondary if the patient was doing okay, improving, and then suddenly started to deteriorate with high-grade fever, thick, greenish secretions, very ill, more distressed. Yes, you might think of secondary pneumonia, bacterial pneumonia. Inhalation, nebulizer. In literature it has no role. I can't explain this without Walaa. Okay? Indications for admissions: age less than 6 months, DSAT, very sick, increased work of breathing, the patient has any attack of apnea or cyanosis, they need to admit, poor oral intake, dehydration, etc. They're all comorbidities, indications to admit. So we don't routinely do radiological or lab investigations, as we say, okay? It's a clinical, mainly a clinical diagnosis. Bronchodilator, systemic epinephrine steroids, all trials, so it shouldn't be part of your regular treatment regime, okay? You try, if the patient responds, okay, you might give as regular or as PRN in the case of racemic epinephrine shouldn't be your regular treatment regime. Okay? Okay. If the patient is admitted with bronchiolitis, you have to apply, as I said, isolation precautions, both droplet, large droplet, and contact, because simply you might do this and then touch a surface. So both contact and droplet isolation precautions. Now the other similar term is bronchitis. Okay, they're very similar. However, the reason why the nomenclature is different now is related to many factors. The main factor is the anatomy of the airway. Okay, as you grow, kids more than 2 years, like 3, 4, 5 years, they have wider airways, so they don't tend to have bronchiolitis. They have bronchitis involving the higher up large airways. Okay. Again, these are the common pathogens to cause bronchitis. Very similar, but with the more possibility to have bacterial etiology more than what we see in bronchiolitis. Okay, like pertussis, chlamydia, and mycoplasma. Again, all you can see in bronchitis X-ray of kids with bronchitis is peri-bronchial coughing. Coughing means thickening of the bronchial walls. Okay, from basic in a cough. We don't routinely start antibiotic unless there is strong indication. Okay, this shows the isolation precautions. So we've got contact, airborne, and droplet. So airborne, when we're talking about airborne infections like tuberculosis, smallpox, chickenpox. هذول كلهم small نسميهم احنا airborne هو very small droplet. Okay, دي محتاج negative pressure dose, محتاج N95 mask. Okay, other form of isolation, respiratory secretions of droplets, maybe RSV bronchiolitis or bronchiolitis in general. Okay, in contact حكينا بالbronchiolitis we have both the droplet and the contact. Someone with an enteric illness and the gastroenteritis has vomiting and diarrhea, do we apply droplet? Excellent. Contact. And droplet is related to the respiratory tract, not the GI tract. Okay. So لما احنا ندخل مريض نكتب له دائما isolation order. إذا المريض ما عنده شيء contagious نقول standard admission precaution. For example, someone with UTI is not very highly contagious, فما بضيع isolation room. Back to standard isolation precaution unless the patient has UTI due to a resistant microorganism. Okay. As I said, contact, droplet, and airborne according to what etiology I'm dealing with. Syndromic-based precaution يعني هذا الترم ما بنسمكم يعني معناه انك انت تعمل isolation according to the presentation case by case. So with standard precaution شو بنعمل standard precaution؟ ما بنلبس gown. شو كمان؟ مش شرط نلبس ماسك. الستاندرد تمام؟ بس لازم اغسل ايدي قبل ما ادخل على المريض ولما اطلع. لازم اغسل ايدي قبل ما البس الجلوفز ولما اشلحهم تمام؟ This is standard precautions, okay? And إذا في شيء أي waste من المريض needles they have to be discarded in the proper way. For example, the sharp needle box, anything that's contaminated by the patient, like the UTI, the kid has urinated, for example, around. You have to make sure that the area is clean. فلازم نحطوا specific bags تاخذوا على المنطقة. So these are the standard precautions. The contact precautions, زي if I have them with gastroenteritis rota, for example, it's very high contagious. فلازم نلبس gown and gloves. هذا إيش ما بنشوفه للأسف في مستشفياتنا. The droplets, you have to wear a mask. It's transmitted through respiratory droplets. Airborne, as we said, with tuberculosis, smallpox, chickenpox. Negative pressure isolation room with a N95 mask.
5 minutes نزل البرزنتيشن